Ma'am, we are live now. I'm going to start.
Yes.
A very good evening, everyone. I'm Ms. Bakadri and Shubham Bharti will be the moderators for today's session. We welcome you all to the Cynodent Webinar Series 2023. Theme of the series is Unlocking the Trends in Dentistry. For the first session of today, I would like to invite Dr. Juwaria Sayed ma'am. Ma'am did BDS and MDS from GDC Mumbai. She has more than 35 years of experience in the field of dentistry. Ma'am has published various books and articles in national and international journals. Topic for this session is Love for Pink and White. I would like ma'am to please start with the presentation.
Thank you, Misbah. It's my pleasure and honor to be the part of Cynodent for this particular presentation. Good evening, everyone. Today's topic is love for pink and white in dentistry. Now, love for pink and white is pink is referring to the gingiva, which is very, very important, and white refers to the tooth portion. So here we will have the presentation on love for pink and white aesthetics. I would like to stress here, for any prosthodontist or dentist, the success is very, very important, which depends on hard work, persistence, late nights, rejections, sacrifices, discipline, can be criticism, doubts, and failure and risk. All these are contribution part for the success. So coming to today's session, that is love for pink and white aesthetics. I refer here again, the pink is the supporting tissues, which are the gums and the gingiva, which is very, very importantly supporting to the white structure. Both goes hand in hand, and respect for both is progress and success in dentistry and more efficiently for a prosthodontist. So today contents of my lecture is pink and aesthetic score, white aesthetic score, implant position, implant abutment, transitional contour. What is pink aesthetic score? The pink aesthetic score is the gingival response to an anterior aesthetic evaluation, which is assessed by the pink aesthetic score, that is PES, which refers from clinical photography according to the 6 variables, and the score is from 0 to 2. Pink aesthetic score. The first is mesial and distal papilla. You can see on the screen, number 1, mesial and distal papilla. Number 2 is the keratinized gingiva. Number 3 is curvature of the gingival margin. 4 is level of the gingival margin. 5 is the root convexity, torque. And 6 is the scar formation. Now coming again to the mesial and distal papilla, which are assessed by complete papilla refers to score 0. Incomplete papilla refers to score 1. Absence of papilla refers to score 2. The keratinized gingiva is scored by thick biotype, that is score 0. Thin biotype is score 1. And absence of keratinized gingiva is score 2. The curvature of the gingival margin, which also refers or defined as the line of emergence of the gingival margin, which is evaluated as being identical to comparative teeth, is score 0. Slightly different is score 1. Markedly different is score 2. The level of the gingival margin is scored by the comparison to the contralateral tooth in terms of identical vertical level is score 0. A slight less than 1 mm discrepancy can be score 1, and the major, that is more than 1 mm discrepancy, is score 2. The root convexity the root convexity, this whole portion, which is the labial eminence, which combines three additional specific soft tissues parameters as one variable. So presence of that is score 2, partial presence is score 0, absence of convex profile in the facial aspect is score 1. The scar formation is scored by absence of scar will be calculated as score 0, partial presence is score 1, apparent presence is score 2. White aesthetic score. The white aesthetic score can be separated into anterior segment evaluation and single one from clinical photography for microaesthetic. Again, 6 variables are scored, which is from 0 to 2. So this is the white aesthetic score. We consider here as 6 parameters, that is midline. This is the incisor curve. Then comes the axial inclination. This is the contact area. This is the tooth proportion and tooth to tooth proportion. The white aesthetic score single, which needs to be evaluated on mesial and distal outline, the crown margin, the translucency, U and value, and the tooth proportion, which we all need to have while preparing the tooth for any type of restoration. So the midline, which is the upper midline equal to lower midline, can be score 0. Midline offset that is less than 3 mm is score 1. Midline more than 3 mm is referred to score 2. The incisor curve, which is scored by the smooth curve, that is score 0. Uneven curve can be score 1. Missing or crowding dentation can be score 2. The axial inclination, the alignment is very, very important. So we need to have this standard angulation, which is again 5 degree, 8 degree, 10 degree. So that refers to score 0. Slightly different than that is score 1. Crowding or spacing is score 2. The contact area. The contact area, here we need to have the ratio of the contact area to crown length from central incisor to canine. These areas from central incisor to canine, which are from 50%. The ratio starts from 50% to 40% to 30%. This score is evaluated as 0. Asymmetry of the contact area on right and left anterior segment is score 1. Slight prolong of the contact area can be score 2. The tooth proportion. 0.8 is score 0. Slightly too long is score 1. Way too long is score 2. Tooth to tooth preparation, which is followed as golden proportion, is 1:6:1 and is 2.6. So that will be rated as score 0. Slightly discrepancy in this can be rated as score 1. Missing or crowding can be rated as score 2. White aesthetic score single. This is very important aspect, which is the score of 2, 1 or 0, which is assigned to all 6 parameters. Thus, in case of an optimum implant tooth restoration, a minimum total of white aesthetic score of 0 is recorded. All the 6 parameters are assessed by direct comparison with the natural contralateral reference tooth, estimating the degree of match or eventual mismatch. In the case of an optimum duplication of the aesthetically relevant features inherent to the control tool, a minimum white aesthetic score of 0 is possible. So implant position is evaluated for mesiodistal position, which is in center. Buccolingual position is 2 mm. The depth is 3 mm. The angulation is maximum to 15 degree. And distance to the tooth is less than distance to the anatomy or the adjacent tooth anatomy is less than 1.5 mm. All these aspects are very, very important for implant position. Sorry. The mesiodistal position, drilling hole always keeps it in the center of the design crown. That is score 0. Shift to one side is score 1. Close and touch to the adjacent tooth is score 2. The buccolingual position, to preserve 2 mm buccal bone thickness after implant placement is score 0. The buccal bone plate exists and less than 2 mm is score 1. No buccal bone plate is score 2. The depth. The implant fixture should be placed 3 mm below the future crown margin, which is score 0. Less than 3 mm is score 1. Deeper than 3 mm is score 2. Angulation of the implant axis should be, always keep in mind that it should be parallel with the adjacent teeth, which is score 0. Less than 15 degree is score 1. More than 15 degree is score 2. Distance to adjacent anatomy for single implant fixture should be at least 1.5 away, 1.5 mm away from adjacent teeth to preserve the proximal bone loss, which is score 0. Less than 1.5 mm is score 1. And touch to adjacent tooth or other important anatomical structures is score 2. Implant abutment transitional contour. This topic has 9 parameters. Number 1 is fixture cervical design. 2 is platform switching. Then comes the implant abutment connection type, abutment selection, screw hole position, marginal bone loss, the sulcus height, modified gingival contour, and crown margin fit. Coming to fixture cervical design, for aesthetic consideration, it is important that we can select the bone level implant which has no smooth collar on the cervical portion of the fixture. The platform switching and most taper design prevent the micro gap movement and allow for a beautiful keratinized tissue response. It's very, very important. Now here we give stress what is platform switching. The platform switching is a method which is used to preserve alveolar bone levels around the dental implants. This concept refers to placing the screwed or friction fit restorative abutments of narrower diameter on implants of wider diameter, rather than placing abutments of similar diameters referred as platform matching. So that is the difference between platform switching and platform matching. Here comes the implant abutment connection type. External connection, internal connection. For example, EZ Plus implant has platform switching design, which maintains crestal bone, and in addition, it incorporates an 11-degree Morse taper, producing a concealed seal, which forms a cold weld between the abutment and the implant. So that is what is very, very important, the implant abutment connection. Then comes the abutment selection, which is screw retained or the cement retained. For cement retained abutment, there are many choices for different situations. It could be one piece, it could be two-piece milling, UCLA, customized abutment, according to the different clinical situations we come across. The screw hole position. Here is the B is the buccal side, L is the lingual side. In this case, the screw hole has left on the labial surface of the abutment. So the screw retained prosthesis will cause anesthetic appearance because of obvious screw hole while patient smile, which is not acceptable. Marginal bone loss. There is no bone loss at the time of crown delivery. So that is score 0. Then comes no pain or tenderness upon function. 0 mobility, less than 2 mm bone loss at the time of crown delivery is score 1. And more than 2 mm bone loss is score 2. Again comes no pain or tenderness upon function. 0 mobility, again has 2 mm less bone loss at the time of crown delivery, which is score 1. And more than 2 mm bone loss is score 2. The sulcus height, 3 mm for biologic width will be maintained as score 0. Less than 3 mm is score 1. More than 3 mm is score 2. Modified gingival contour, 100% papilla filling, which is score 0. Papilla less than 100% fill is score 1. No papilla is score 2. So, in all, I would like to give a wonderful message for all of you. You need to have a success. Success can be scored or rolled if you keep these points in your mind. For success, S is see your goal. You understand the obstacles. C is create a positive mental picture for all of us. C again is clear your mind of self-doubt. E stands for embrace the challenge, stay on track, and show the world you can do it. Thank you.
Thank you so much, ma'am, for the informative session, as you beautifully and simply explained all the things in the session. Ma'am, we have a few questions for you from participants. Should I begin?
Yeah.
What are the latest development in a dental implant surface treatments for improved osseointegration?
Yeah, we have various systems which can be improved. For example, if we are using a strongman, which has got very beautifully given the design and is compatible for any type of patients, but the cost of it is too high. That is what. But it needs to motivate it and explain to the patient so that the patient offer these systems. But we have locally made also. Adine is there. We have Austin, but that is also comparatively well placed and very good technique use, have a huge success for any of the type of implant systems.
Ma'am, we have a next question. What is the right way of the occlusal adjustment of the implant supported crown?
Yes, the right way is to we have to see the proper natural occlusion first. How is it? We can't give more stress or more force on the abutment or the crown which is placed on the implant. So we keep it slightly under this so that there will be not more space, but occlusion should be adjusted. That is consideration only for single. If it is full mount, we have to give respect to all the bone part, the soft tissue part, everything. We should be coordinated, and it should have a proper occlusion. That is, we need to have an occlusal key, whether it is canine guided or whether it is a full mouth occlusion, which is all over considered as the best acceptable for the soft tissues, which is very, very important.
Thank you so much, ma'am. For you explained it so nicely. I would like to thank our founder and CEO of Cynodent, Dr. Anmol Bagaria, ma'am, and co-director of Cynodent, Dr. Ashish Chandra sir, for organizing this webinar series, and my co-moderator, Dr. Misbah Kadri. Also, thank to all participants who joined us today, and I kindly request all the viewers to please like and subscribe on our YouTube channel for getting daily updates and webinars. Thank you so much.
Thank you, Cynodent. Thank you, Shubham. And thank you, Misbah, for this cooperation. I'm proud and pleasure to have you all in this with
Thank you so
Cynodent.
much.
Thank you so much.
Thank you so much, ma'am.